Professor of University of Chicago Center of Airway Disease, and who is going to talk about the hybrid management of complex TIVA involving the aortic zone 1 and the zone 2 cases. Thank you.
Great. Thank you very much, and thank you for the invitation to be here at this great meeting. This last session was amazing. I know I'm the last speaker before you guys get to have lunch, so I'll try to be efficient. But I think what I have in some of my case presentation as well actually really echoes some of the difficult and complex nature of taking care of these patients. So I just wanted to thank Dr. Poon. I've been in Thailand before. I think he had a lot to do with me being able to be here today, and I appreciate that. So I want to share a case, and this actually shows very well with all the controversy with intramural hematoma. We actually initially met this gentleman when he was 37, which was about 7 years ago. He had an IMH at initial presentation, and it was felt by one of my partners initially that his symptoms did not resolve, as Dr. Criado said. His pain persisted, and he actually got a TEVAR done in a way that actually, in retrospect, I probably wouldn't have done, but either way was sort of proximal descending, but did not go all the way up to the left subclavian artery. He subsequently developed a complication which we fear, which was about 4 days later. He developed retrograde IMH that actually compromised his aortic valve and developed a pericardial effusion and had an ascending aortic replacement done. He has had progressive aneurysmal degeneration of this interval segment between the ascending graft and the TEVAR, and then just earlier this year underwent a reduced sternotomy with a graft to the left subclavian artery with an elephant trunk, a standard open elephant trunk, and branches performed to the innominate and left common carotid artery in preparation for TEVAR for the remainder of the arch disease. So here's what his imaging now looks like after his most recent operation. You can see the large aneurysmal degeneration, the aortic ascending replacement, the TEVAR, which looks good, and there's no problem distal to the TEVAR. And this is what it looks like on just a reconstruction, and you can see the markers from the elephant trunk. So we actually did this case recently with what for us has been FDA approved back in November for the Navion device. Here you can see an intraoperative angiogram where we've been able to cannulate the elephant trunk, and then chose for this case a covered seal, as there's two different configurations available for this device, and felt that the covered seal would be the best option in all graft. Here you can see the device in place, and then deployed, and then this was done with a small piece to match with the graft, and then a larger piece that was brought down into the old TEVAR with a technically good result. So specifically what I've been asked to look at is how do we deal with these complex anatomies in this difficult arch zones? And Ishimura's classification really helps all of us speak about this in a standard way. We've heard that through all the talks throughout this session. I actually find the non-A, non-B discussion to be one of the most interesting because at our center, we have a very good collaboration between cardiac surgery and vascular surgery, and every fight we have is over the non-A, non-B, who's going to take care of that patient. So the zones are good to know. So traditionally what we do from a traditional standard surgical approach, in the past when you have zone 1, potentially zone 2 disease, but where you have a difficult landing zone, is a 2-stage, 2-cavity procedure that required an elephant trunk. Obviously it requires cardiopulmonary bypass and circulatory arrest. You can eliminate this with a single cavity approach, as you've seen with multiple times here. We don't, obviously, as you just heard from Dr. Caselli, don't have FDA approval for the devices, but it can be done with a sternotomy, a debranching, and an antegrade approach with a TEVAR or retrograde, depending on how you'd like to do it. This is an old example from when I was in Atlanta a number of years ago, where an arch debranching was performed. An antegrade deployment is then done with a sheath through a conduit in the ascending graft, and then you can see 2 thoracic endografts placed, so this can be done in a single stage. So there are many different ways to surgically debranch the arch. Depends, I think, on what region of the world you're in and what is your preference in terms of how to do this. But the goal with all of this is to gain an appropriate landing zone so that you can get a device in place and revascularize all the crucial vessels. But obviously what all of our goals are, and what most of us feel like, is sure, we can still do these surgical debranchings, but they do have complications. And if there's a way to do this in a completely endovascular fashion would be ideal. And I think all of the device companies that we work with are working from, let's get from a single branch further on and be able to treat the entire potentially ascending aorta all the way throughout. Here again is just showing you a demonstration of some of the different revascularizations that can be performed. A single branch